So in this video, we're going to look at the endocrine pancreas and insulin and some of the other endocrine pancreas hormones in more detail. So again, the endocrine pancreas consists of the islets of Langerhans. They were discovered in the late 19th century by the German anatomist Paul Langerhans. They're actually just visible to the naked eye. They're about 0.1 millimeters in diameter. That's about the size of a human egg cell, interestingly, and that's the only cell that's visible to the eye. But these islets consist of thousands of cells, so they're not just a single cell. They constitute only about 1 to 2% of the mass of the pancreas, but loss of these cells, especially the beta cells and insulin, can be devastating, leading to type 1 diabetes in that case. There's about 3 million islets scattered throughout the pancreas, and there's little fibrous tissue that separates each island from the surrounding tissue. If you took all of the islets out and weighed them together, they constitute a mass of around 2 grams or so. But again, incredibly important. So here's just a little representation of, number one, the exocrine acinar cells, which we just talked about in the last video. These are the enzyme secreting cells. Here is a blood capillary. Here is the pancreatic duct. This is going to fuse into the pancreatic duct in the duodenum, so the acinar cells are going to drain into that. But the islet is all of this in here. And that's going to consist of several different types of cells. The most prominent cell is the insulin-producing beta cells. That's in orange here. But then you see there's also in yellow the glucagon-producing alpha cells. And then we have the pancreatic polypeptide cell, less common, the somatostatin delta cells, and so forth. So all of those are going to secrete their secretions directly into the capillaries. And again, that's going to all end up in the portal vein going to the liver first. So in terms of the actual hormones, the alpha cells again secrete glucagon. They are about 15 to 20% of all of the pancreatic cells. And they're going to bind to glucagon receptors, specifically on hepatocytes and on renal cells. So that's really the main targets of glucagon. So liver, a little bit kidney. And that's going to promote in the liver glycogenolysis, which is the breakdown of glycogen into glucose, and then gluconeogenesis, the production of new glucose from some amino acids, lactate, and triglycerides. The glycerol backbone of triglycerides is made into sugar, into glucose. And the secretion will be stimulated by hypoglycemia, so low blood sugar, epinephrine from your adrenal medulla, as well as a little bit of acetylcholine and cholecystokinin. But it's mostly, we think about the epinephrine as the primary stimulus for glucagon release. The secretion is inhibited by somatostatin, again by insulin, and by another enzyme, PPAR gamma. So that is glucagon. The beta cells, much more predominant, up to 80% of the cells in the islets are beta cells. They secrete insulin. In the process of making insulin, we also secrete something called C-peptide. We'll look at that here shortly. And then amlin is a second hormone produced by the beta cells. The ratio of insulin to amlin is about 100 to 1, so it's mostly insulin. Now the beta cells are interesting. They have several proteins and channels in their surface. They have an ATP-sensitive potassium channel. There's a voltage-gated calcium channel. There are receptors for GIP and GLP-1. These are called incretins, and incretins are released also by duodenal cells. What happens is when glucose reaches the duodenum from the chyme that's come through the stomach, if there's glucose in there, it's going to cause the release of GIP and GLP-1. These are going to enter the portal system, eventually make their way to the pancreas via the arterial system, and then that's going to bind to receptors on the beta cells, and that will tell the beta cell to release more insulin. So that's why, interestingly, if you eat glucose, you get a good surge of insulin in the blood after that, versus if you were to intravenously deliver glucose to somebody, they actually don't get much of an insulin response. They don't secrete much insulin response to that. So it's the glucose coming through the GI tract. These are the hormones that stimulate that. We're going to see a lot more of these later when we discuss diabetes, because there are actually medications that are GLP-1 agonists, and they're peptides that are given by injection, usually like once a week or once a month, and they are basically stimulating those receptors on the beta cells to kind of help them work a little bit better. And the whole role of insulin is to actually decrease the concentration of serum glucose. Now, I'm going to say a little bit about how insulin is released here in just a moment, but let me talk about amylin first. Amylin really is going to slow, when it's released, it's going to slow gastric emptying. It's going to promote satiety, and it prevents any postprandial spikes in blood glucose. So essentially it's assisting insulin by slowing down the rate at which the food is going through the stomach, and it's going to tell the brain, hey, let's slow down on our eating so that we can process what's come through here already. So we can think of amylin as assisting. There are actually amlin analogs, and these can be used for diabetes. They're taken along with insulin often to sort of help promote the insulin action. They have to be taken with every meal, injected. It's not convenient and they're expensive, so we don't typically see those prescribed, but they are actually on the pharmacopoeia, and they are one of the agents that can be used for diabetic patients. So in terms of the molecular physiology of the pancreatic beta cell, what ends up happening in terms of insulin release is interesting. So when the glucose levels rise in the blood from absorption from the GI tract, there are glucose transporters on in the membrane of the beta cell, and we'll look at the different glucose channels in a little bit here. And when the glucose comes into the beta cell, that's going to increase metabolism. The beta cell will make more ATP, and so the ratio of ATP to ADP goes up. And what ends up happening then is the increased ATP will actually close this potassium channel. So the potassium channel normally is allowing potassium to leave the beta cell. Potassium has a positive charge. So if you close the channel, more positive charge will actually increase on the inside here. And what happens then is that the membrane will actually depolarize. And so the membrane depolarizes, and that causes this voltage-gated calcium channel to now let calcium in to the beta cell. And when calcium comes into the beta cell, it's going to allow these vesicles, which have stored up insulin, to fuse with the membrane, and that's going to release the insulin into the blood. So we need the glucose coming in through the channel. We need the closure of the potassium channel, which then causes depolarization. And then that's going to cause an opening of the calcium channels. Calcium comes in, insulin is released. Now, not shown here, of course, will be the receptors for the GLP-1 and the GIP, and they're going to assist this process as well. There's another drug class we'll see with diabetes. They're called sulfonylureas. And sulfonylureas are interesting because they work by actually artificially, we could say, closing the potassium channel. And so they're going to trigger the same effect as glucose had by coming into the cell, making more ATP. The sulfonylureas will actually close the potassium channel. That'll depolarize the channel, calcium channel opens, insulin is secreted. So that'll be another drug class that we'll see is the sulfonylureas. So those are still used. They unfortunately have a side effect of increasing hypoglycemia. So they're one of the few diabetes drugs that really has a problem with that. So people can get very hypoglycemic. Insulin, of course, injected would have that effect as well. But the sulfonylureas are basically trying to whip a tired beta cell into functioning more. So they actually have a limited lifespan over maybe a decade or less. As the pancreas, as the beta cell wears out, they'll become less and less effective. Again, we'll talk a lot about diabetes later, but basically Type 1 diabetes, of course, is where the beta cell no longer secretes insulin, and that's usually due to autoimmune destruction of the cell. So the immune system destroys the islets and especially the beta cells. And there's actually antibodies that are released against some of these different peptides, proteins in the beta cell, as well as against insulin. So that's type 1 diabetes, DM1. But DM2, type 2 diabetes, the beta cells, at least in the early stages, are fine. In fact, it's the receptors for insulin in the muscle and the adipose which become insensitive to insulin. And so they're not able to get the glucose into them like you need. And so what happens is the beta cell actually ends up increasing insulin secretion. So people with type 2 diabetes in the early and mid stages actually have elevated insulin. Versus in type 1 diabetes, we get decreased insulin. So that's why sulfonylureas actually can be helpful. They actually increase the insulin even further. Same with the GLP-1 and the GIP agonists. They do the same thing. But over time, in type 2 diabetes, the beta cell actually becomes fibrotic, becomes filled with fibrous tissue and scar tissue, collagen, and it actually accumulates amyloid, which is very similar to what happens in Alzheimer's. This is misfolded proteins inside the beta cell. And that actually destroys the beta cell, and the insulin levels now plummet. And so in late stage type 2 diabetes, we get decreased insulin, and that's where people may need to be on insulin injections and so forth. So again, we'll discuss that with diabetes. So those are beta cells. I'll just say a little bit about the other cells here. So delta cells they're only about 3 to 10% of the islet cells. They produce somatostatin, and that's going to inhibit both the alpha and the beta cells from secreting insulin and glucagon. It's also going to decrease stomach acid, suppress other GI hormones, and suppress growth hormone. And we see that in the pituitary. Somatostatin is one of the inhibitors of growth hormone. In fact, it used to be called growth hormone inhibiting factor. And it suppresses exocrine pancreatic activity. So think of this as the brake on the system, somatostatin. PP cells secreted by gamma gamma cells secrete pancreatic polypeptide, and that's helpful in the regulation of the other pancreatic secretions. It also influences the liver glycogen levels and other GI secretions. So think of that as a supporting peptide. And then epsilon cells produce ghrelin, which is the hunger hormone, and that's secreted when the stomach is empty. Basically, when no secretin and so forth is sort of stimulating the pancreas, it releases ghrelin, and that's going to act on the brain to increase hunger, saying, okay, we're ready for more food. So that stimulates the feeding signal. All right, so that's the overview of the islets of Langerhans and all the major hormones that they secrete. So next, let's focus on insulin in more detail. This is, of course, secreted by the beta cells. It's a peptide hormone. Remember, peptide hormones cannot be taken orally. Your digestive enzymes would break them down. So the only way we can really deliver insulin would be through injection. There are other methods like intranasal delivery that has sort of come and gone, and it's, I think, recently come back again, but it's not a very convenient way. You have to sniff it, basically, and it can create nasal irritation, as well as this unpredictable levels of absorption. So that's why injection of insulin is still the standard for therapy. Primary anabolic hormone in the body, it's really regulating your anabolic activities, and specifically in your liver, skeletal muscle, and fat and adipose. So those are the primary targets. A lot of other tissues we'll look at, like the brain and so forth, do use insulin, but not to necessarily get glucose into the cells. And so they use insulin more as a signaling hormone. When there is a decrease in insulin, like in type 1 diabetes or late stage type 2, we see widespread catabolism, especially of body fat. So if we look at the actions of insulin, it's basically stimulating in terms of carbohydrates, glycogen storage, synthesis and storage in the liver and in muscle. It's stimulating triglyceride storage, synthesis and storage in the liver and adipose tissue. It's stimulating amino acid uptake into tissues. It's stimulating protein synthesis in muscles. So these are all anabolic. Decreasing glycogen release, decreasing proteolysis, which is the breakdown of proteins, decreasing the breakdown of fat, lipolysis, decreasing the production of new glucose, gluconeogenesis, and decreasing the breakdown of glycogen, glycogenolysis. Another important feature of insulin is that it decreases cellular autophagy. Autophagy is really where the cells auto-digest themselves, and this is actually a healthy house cleaning process. So organelles, as they get old and worn out, need to be broken down, recycled, and that's a normal process called autophagy. Unfortunately, insulin inhibits that, so that's why we're finding with hyperinsulinemia, high insulin levels in type 2 diabetes, the cells are not doing the normal recycling process. They're accumulating their broken down organelles, waste products, proteins, and so forth. And so that's going to create potentially increase aging and accelerate disease. As we'll see, fasting and whatnot, all that's going to decrease insulin, actually increases cellular autophagy, so that is a healing response. Insulin also increases stomach acid secretion. And the idea there is probably just assisting in the the digestive process, increasing the cellular uptake of potassium. So remember, cells concentrate potassium on the inside, and then they have more sodium on the outside, and that's partly maintained by the sodium-potassium ATPase pump. So the insulin actually increases the uptake of potassium into the cells. This is important because in very low insulin states or in insulin resistant states, we see potassium leaking out of the cells and more extracellular potassium. And this, of course, is called, when that gets into the blood, that's called hyperkalemia. So hyperkalemia is actually going to be a sign of, in type 1 diabetes, of diabetic ketoacidosis and so forth. We often see elevated potassium. And what is actually given for patients with hyperkalemia is insulin with glucose to prevent hypoglycemia, and the insulin drives the potassium back into the cell. Insulin also increases the blood levels of sodium, and that's going to be via uptake via the kidneys. Stimulates vasodilation, although interestingly, what we see in hypertension chronically is that insulin may very well accelerate arterial sclerosis, which is the hardening of your small arterioles, which might actually drive up hypertension. So one potential cause of primary or essential hypertension is hyperinsulinemia, like in type 2 diabetes. And that's why we see in type 2 diabetes a huge correlation, huge association with cardiovascular disease, especially atherosclerotic cardiovascular disease. In the brain, we need insulin actually not to get sugar into the neurons. Fortunately, the neurons do not need insulin to get glucose into them, but the glial cells need insulin, and the neurons need insulin as a signaling hormone, and we know that's associated with better learning and memory. In fact, when we have insulin resistance in the brain, we start to see a decrease in that. We also see decreased repair of neurons, increased accumulation of amyloid, and so some people are actually calling Alzheimer's disease type 3 diabetes because of its effects on the brain. And then it also increases gonadotropin releasing hormone from the hypothalamus, and that will improve fertility. So we think insulin has, at least in normal physiologic levels, has a fertility promoting effect. Unlike the glucose, insulin is a peptide, does not cross the placenta. So babies the fetus has to make its own insulin. Insulin is used medicinally to treat type 1 diabetes, and again in late stage type 2 diabetes. And again, it has to be injected subcutaneously, again potentially through nasal sources, the inhalation. But usually we use syringes. There are now increasingly insulin pumps that are being given, and then insulin pens. Now we'll look at the synthesis here next, but basically insulin is going to form as one giant peptide, and that's going to consist of an alpha chain, a C chain, and then a B chain. And they're all linked together when insulin is manufactured. And then in the final step, these three chains are cleaved apart. The beta and the alpha chains are joined, and that's going to form insulin. and then the C-peptide will be a remnant of that. So interestingly, C-peptide levels in the plasma parallel the levels of insulin. And so it turns out C-peptide is a more useful measurement of insulin, especially for people taking insulin, because the lab assays that we have, if a person's injecting themselves with insulin, can't differentiate the insulin that they're injecting versus what the pancreas is secreting. So if we want to know what the pancreas is doing, we usually have to measure C-peptide levels to give us a better idea about that. So the synthesis, again, it's first synthesized in the beta cells, is a single polypeptide. That's the pre-proinsulin. And the pre-proinsulin contains a signaling peptide, which is going to direct it to the rough endoplasmic reticulum. So remember, proteins are synthesized in ribosomes. Then this pre-proinsulin will enter the rough endoplasmic reticulum in the beta cell, and then it's going to that's going to cleave off. There's enzymes there to cleave off the signal peptide, and that is going to become proinsulin. And so the proinsulin is what I just talked about. That has a B, a C, and an A chain. The proinsulin is transported to the Golgi network, and then it's going to form these little blebs. They're going to kind of bleb off from the Golgi network. That takes about 30 minutes. And then inside that, the proinsulin is going to be cleaved into the C-peptide, and then the alpha and beta chains will join to form the insulin. And those are linked by disulfide bonds. The insulin then is going to be packaged and stored inside the granules. And so the C-peptide is going to be with it. And so when insulin is released, C-peptide will be released in the same amount as the insulin. Okay, so C-peptide levels are often a better measure, actually, of the insulin levels in the blood, especially if a person's taking insulin. Okay, so that is the synthesis of insulin, and then we already looked at the stimulus, and we'll review that again here just shortly, of how insulin is released. So in terms of release, again, we already went through this, but basically it's dietary glucose which stimulates insulin release, and it's released in two phases. One is a rapid response to dietary glucose, then there's a sustained release, slow release, which is independent of glucose. So we always actually maintain a basal level of insulin, even between meals, to kind of stimulate all the processes in the body that still need insulin as an anabolic hormone. So just again quickly, the glucose is going to enter the beta cell via the glucose transporter. Now there's several different types of glucose transporters. This is specifically a GLUT2 transporter. Now a GLUT2 transporter have low affinity for glucose, and so the glucose in the beta cell is actually going to be directly proportional to the extracellular glucose concentration. High affinity transporters will take up and concentrate whatever the ligand is or the molecule is, and will concentrate in the cell despite low plasma concentration. So low affinity receptors will bring in proportion to the plasma glucose levels, glucose into the beta cell. That's going to undergo glycolysis. That will also undergo aerobic metabolism in the Krebs cycle and oxidative phosphorylation. That's going to make ATP. ATP is going to close those potassium channels, and that will then cause depolarization of the membrane on the beta cell. That's going to cause the calcium channel to open, and then the calcium will come in, fuse onto those insulin-containing granules, and cause them to release. So that's the kind of signaling process in a nutshell. Again, the potassium channels are known as are responsive to sulfonylureas, and so we also have the term sulfonylurea receptor is another name for those ATP-sensitive potassium channels. Now, importantly, I mentioned earlier that acetylcholine from the parasympathetic nervous system, from the vagus nerve, can also stimulate insulin release, and it does it through a secondary pathway. So this is the glucose-dependent pathway. The acetylcholine pathway basically is via the activation of phospholipase C. So there's actually a receptor, a G protein receptor on the surface of the beta cell for acetylcholine. And when that is activated, it's going to increase the synthesis of what's called IP3, inositol phosphate triphosphate, and that's going to again increase calcium release, but this time from endogenously stored calcium. So there's actually stores of calcium within the cell and in the endoplasmic reticulum, and the net effect is going to be the same as having the calcium come in from that channel. It's going to cause the insulin granules to fuse and to be released. So that is a second way in which insulin can be released via acetylcholine and activation of phospholipase C. So in terms of what triggers insulin release, again, glucose is the primary signal. Now there's some amino acids that release glucose, leucine and arginine in particular. They can actually cause glucose to increase. Acetylcholine we just mentioned via the parasympathetic vagus nerve. Cholecystokinin from the duodenal cells. Glucagon-like peptide, GLP-1, and then GIP. It's called glucose-dependent insulinotropic peptide. It's also given the name gastric inhibitory peptide because it kind of inhibits, just like amlin does, some of the gastric activity to slow it down to allow for proper absorption. And then sulfonylureas, we talked about those stimulating those ATP-sensitive potassium channels. So all of those trigger insulin release, but they're also inhibitors of insulin release, and that would be catecholamine. So interestingly, high stress states, high sympathetic nervous tone will decrease the amount of insulin the pancreas can secrete. Now, there's actually two receptors for catecholamines in the beta cells. There are alpha-2 receptors, and there's also beta-2 receptors. Now, they actually have opposite effects. The alpha-2 receptors decrease the release of insulin. The beta-2 receptors paradoxically increase insulin release, but they're found in a lot less density than the alpha-2 receptors. So the net effect via the alpha-2 receptors for norepi or epi from your sympathetic nervous system is to decrease insulin release. And then we already saw that glucagon from the alpha cells sort of opposes the action of insulin, but it directly inhibits the release of insulin from beta cells as well. Now, I mentioned that insulin is released in bursts after a meal, but even afterwards, there is this sort of continuous secretion of insulin, and we find that insulin is released in little waves. They happen about every 3 to 6 minutes. The beta cells sort of push out insulin. This is an insulin oscillation. So the blood levels oscillate between 800 picomoles and 100 to under 100 picomoles, even between meals. And we think that what the importance of this is so that the insulin receptors in the skeletal muscle and the adipose don't get downregulated, because if they're constantly slammed by insulin, they're going to downregulate. But if you have this nice circadian, this sort of sinusoidal secretion, then that's going to be less likely to happen. It's interesting that a lot of the current insulin pumps don't have that feature to regulate the insulin, to pulsate it in this way, but that might be something that we see in the future. I think that I haven't seen any research connecting it, but my suspicion is, again, if you look at the autonomic nerves, parasympathetic, sympathetic, that innervate the pancreas, they have their own oscillation rates. So you can say they have an endogenous frequency at which they work, and that the insulin secretion is actually a image. Really, it's just the same frequency, but in this case, translated into insulin. So that we can start to think about, could it be that people with a lot of pancreatic disorders, even in type 2 diabetes, are actually having the improper nerve input into the pancreas? And could we support that with therapies like acupuncture, herbal therapy, even some interesting work looking at light therapy, yellow light therapy, for example, actually shined over the skin, can be detected by photoreceptors in the skin, chromophores, and these can affect the oscillations and the activity of the nerves. This is all speculation, but it's something we might find more research in the future looking at. I do sort of have that intuition clinically that that's kind of what a lot of our therapies are doing, is actually improving the autonomic tone to the pancreas, and that has a direct effect on insulin secretion, in this case the insulin oscillation. So let's look at the insulin receptor here now. So insulin's released, it's in the blood, and it has to interact with an insulin receptor for it to be active. That is a cell membrane. It's a tyrosine kinase receptor. Remember, tyrosine kinases is one of our 4 major types of cell receptors, and a kinase is basically an enzyme that is going to attach a phosphate group. It's going to phosphorylate different proteins within the cell, and that's going to activate them, basically turn them on. There are in the insulin receptor alpha subunits, which are more on the outside of the cell, and then there are beta subunits, and that's directly attached to the kinase enzymes, the tyrosine kinases. So the alpha units are the insulin binding sites. The tyrosine kinase activity is going to, again, promote phosphorylation of proteins inside the cell, and we call those insulin receptor substrates. And that's going to lead to a whole signal transduction cascade. And this diagram to the right is really simplifying things. There are actually hundreds of steps here. But this is going to mediate the intracellular effects of insulin. And we can kind of boil them down to 2 major pathways. The MAP kinase signaling pathway is going to stimulate a lot of the anabolic effects of insulin, like cell growth, proliferation, and gene expression. And those genes are going to make a lot of the proteins needed for cellular energy metabolism and so forth. The PI3K pathway is going to work with stimulate the synthesis of lipids, proteins, and glycogen. It's going to promote cell proliferation. It's also going to downregulate that autophagy that I talked about. And then it's going to also release glucose transporters that have already been synthesized and stored within the cell, but it's going to cause them to fuse with the membrane of the cell, and that's going to allow glucose to come into the cell. So in cells that have that need insulin to get the glucose in, this is how the insulin is going to cause the insertion of these glucose transporters so that glucose can come into the cell. Very complex process, but this is happening, within milliseconds, and so it's a very fast process. This is what is going to, in skeletal muscle and adipose in particular, the main glucose transporters are called the GLUT4 transporters. They are insulin dependent, meaning the only way you can get those transporters into the membrane is via the insulin signal. So the primary intracellular effects of insulin, just to summarize there, would be through the MAP signaling pathway to increase gene expression, growth regulation, through the PI3K pathway, that's going to be to increase the GLUT4 in the cell membrane. It's also going to stimulate the glycogenesis, that's the synthesis of glycogen in liver and muscle cells. Going to stimulate triglyceride synthesis in liver cells and adipose, stimulate protein synthesis in most cells, and then decrease the breakdown of triglycerides, especially in adipose. I should say in the liver, insulin will also increase triglyceride synthesis. And this is unfortunate because it can take a lot of the excess energy from calories, turn them into fats basically, and then the liver either has to store that inside the liver, and that can create fatty liver. And that is sort of this epidemic we're now seeing with a lot of type 2 diabetes where we oversecrete insulin. That causes the liver to store up too much fat, and we get non-alcoholic fatty liver disease, which can progress into hepatitis or even liver cancer and cirrhosis. The liver also puts out more VLDL, which is saturated in triglycerides. That's the very low density lipoprotein. So it tries to transport the triglyceride out of the liver. And that in the bloodstream becomes LDL, the so-called bad cholesterol. And so that's a problem. Not written here, I should say, is that insulin stimulates the rate-limiting step in the liver for cholesterol synthesis. So remember, in the body, most of the cholesterol does not come from the diet. It actually comes from liver synthesis from acetyl-CoA. And acetyl-CoA really comes from the breakdown of glucose. So glucose metabolism, it comes from fatty acid catabolism, beta oxidation, and it also comes from protein catabolism. So the end product of metabolism is acetyl-CoA. And unfortunately, in the liver, there's actually an enzyme that can take acetyl-CoA. We actually need some amount of cholesterol in the body, so we can manufacture, through many steps here, cholesterol from acetyl-CoA. Can also manufacture fatty acids and triglycerides. Remember, a triglyceride is glycerol with 3 fatty acids attached to it. So the liver from acetyl-CoA can make both cholesterol and triglycerides. Insulin is the signaling molecule which actually activates the primary enzymes in both of those steps. And so that's why insulin we think of as a kind of anabolic building up hormone. So this is a real problem because the cholesterol and triglycerides are packaged in the liver. They're either stored in the liver, but once the liver kind of reaches the brink and can't store anymore, it creates this lipoprotein called VLDL, and that's going to enter the blood, and as triglyceride leaves and goes into tissues, that's going to become LDL, which is very rich in cholesterol and cholesterol esters. And that's going to deliver cholesterol to your tissues, and that's why we often call that the bad cholesterol. Again, we need a certain amount of cholesterol, so it's not that cholesterol is bad by itself, but if there is systemic inflammation, all the risk factors for atherosclerosis, that cholesterol from LDL, a lot of it will pack into arterial walls, into the macrophages, creating foam cells, and that'll create more arterial plaque. The LDL eventually will come out of circulation. It's going to go back to the liver. There is what's called the Ldl receptor. So the liver, if it expresses adequate Ldl receptor, will take it out of circulation, and then it's going to eliminate that through the bile. And so if you have good fiber in the diet, whatnot, that'll carry all that out of the body. But this is a real problem. So we can think of insulin as directly driving up cholesterol levels, and this is why one of the features we have with hyperinsulinemia and type 2 diabetes is a significantly elevated risk of atherosclerotic cardiovascular disease. Okay, so that is some of the major effects there of insulin. Again, myocytes and adipose are the most influenced by insulin. They're going to actually need insulin to get sugar into them, to get glucose into them. Liver is also, as I just talked about here, very highly dependent on insulin for all these functions with carbohydrates, proteins, and the lipids. But interestingly, the liver does not need insulin to get glucose into the liver cells, the hepatocytes. In fact, this is where the glucose transporters come in. So there are 2 different types of glucose transporters, insulin-dependent and insulin-independent. So insulin-dependent glucose transporters, this actually should be glucose transporter, not insulin transporter. So the insulin-dependent glucose transporters would be the GLUT4 that I just talked about, and they're found in adipose and striated muscle, so all your skeletal muscle. The insulin-dependent, independent transporters would be the GLUT1s. They're found in red blood cells in the brain, especially your neurons, cornea. GLUT2 are found in the beta cells, so remember that's the glucose, the low affinity transporter that's going to allow glucose to come into the beta cell. These are also found in the liver, the kidney, and the small intestine. And then GLUT3 is also found in neurons and glial cells. So these do not need, these transporters don't need insulin to get glucose into them, but insulin does still play a role. There are insulin receptors in those tissues. And through these other pathways, the MAP kinase pathway, for example, the insulin is having pro-growth, pro-anabolic effects within the cell. So the brain normally utilizes glucose for metabolism. It can depend on ketone bodies during starvation, but fortunately, because we don't need insulin to get glucose into the neurons, we don't die as soon. Type 1 diabetics would be fatal very quickly if they didn't have that. But they're able to still get the glucose in, and then in starvation states, we can use ketone bodies as a fuel substrate. Even in starvation, though, the liver the brain still continues to rely on glucose, and the liver continues through gluconeogenesis to put out glucose. And so it's the last organ that keeps using the glucose in the body. The other tissues, muscle and whatnot, can rely more on the ketone bodies. Red blood cells also utilize glucose because they actually have mitochondria, and they don't have mitochondria, and so they can't do aerobic metabolism. Okay, so that's the whole pathway there with insulin signaling. Again, know the difference between the different glucose transporters, GLUT4 versus GLUT1, 2, and 3. These are non-insulin independent transporters. And then we have our insulin degrading enzyme that's called insulin protease. That's found mostly in the liver, a little bit in the kidney, and that's going to eventually inactivate insulin. And so insulin has a half-life of about 4 to 6 minutes. Most of it's degraded within an hour of secretion or injection. Now, with the medicinal insulins, the ones that are used pharmacologically, the regular insulin is what is closest to human insulin, and that has a very short half-life. And there are actually some insulins that have even shorter half-lives that are taken maybe after a meal to stabilize blood sugar. But then we have insulins that actually are now stabilized via in different ways. So they actually have a much longer half-life. In fact, some of them actually have a 24-hour half-life, roughly. And so they can be injected once a day, and that creates a basal level of insulin. So we'll look at the therapeutic use of insulin in the diabetes section, but that they would have different half-lives. Okay, so that summarizes it. I think there's one picture here from Nature Reviews, which is maybe helpful. Again, looking at some of the steps in the intracellular signaling pathway. Now, one thing I want to say is when we talk about insulin resistance, we're finding insulin resistance is more complicated than we thought. It's not just resistance at the receptor. It can be resistance in a problem of any one of these intracellular signaling pathways. And so this is where we're finding kinases, those enzymes that can phosphorylate, are very important. But it's not as simple as just working with the receptor. It has to do with the breakdown, often intracellularly, of these intracellular signaling pathways. And so we really don't have therapies yet that can target at all these different levels. I'll talk about some of the agents, especially some of the botanical agents we think actually can upregulate some of these intracellular signaling pathways. And so they provide some novel approaches to diabetes. Now, this is more to sort of help integrate more traditional views in medicine with kind of the biomedical aspects we just discussed. And if we look at Chinese medicine, for example, they have this notion of the spleen qi as the primary driver of metabolism and digestion. And so this is often discussed clinically. More specifically, what is called the earth phase is what regulates digestion, and that includes two organs. What in Chinese medicine is the qi, and that's translated often as spleen. This is the yin aspect of earth, and then the wei, which is translated as stomach, and that's the yang aspect. We call this the organ of rotting and ripening. So it makes sense from a biomedical sense, because that's what we think the stomach does as well. So the questions that arise are, what are the biomedical correlations to Chinese spleen? Because anatomical spleen, biomedical spleen, really we don't think, except for in terms of the immune activity, has much relationship with digestion. And then how does the Chinese spleen, again, relate to that anatomical spleen? So if we look at the functions of the spleen first in Chinese medicine, again, it's been translated as spleen, but the Chinese term is P, if I'm pronouncing that correctly. The spleen and stomach are responsible for the storehouses and the granaries. The 5 tastes stem from them. So this comes from a classic of medicine, the Yellow Emperor's classic of internal medicine, the so-called first part of that is called the Su Wen, this is chapter 8. And this is kind of using more metaphoric language to look at the processes and the functions of the different organs. So we have a storage function as well, something around the taste and so forth. But it's said that the P really is responsible for transformation and transportation. So it extracts the essence of food, governs digestion and assimilation, distributes nutrients and fluids. Again, if we just think of biomedical spleen, doesn't seem to have anything to do with that. The P also is said to produce the blood and regulates the blood. Well, in terms of biomedical blood production, that's the bone marrow in adults. The spleen, anatomical spleen, does actually participate in production of red cells in the fetus, but not in the adult. And it says there's a holding function. So by regulating the blood, it says the Chinese medicine terminology describes how the spleen holds the blood in place, so it prevents hemorrhages and prolapse and things like that. Again, I'll just list out these functions and we'll maybe think about some correlations. We say the P rules the flesh, nourishes the muscles and the four limbs, and the spirit of the spleen, or the P, is Yi, which governs thinking, memories, ideas, especially the ability to focus and concentrate intellectually. That's related to the spleen aspect. So key problem areas of a deficiency or an imbalance in the P organ in Chinese medicine would be GI, indigestion, loose stools, bloating, pain, undigested food in the stool, low appetite, early satiety, poor energy, lassitude, fatigue, say dampness, and that would be accumulation not just of physical mucus like in the lungs, but we can say an increase of the mucosal lining in the stomach and small intestine and the large intestine, and an overgrowth of bacteria there. And that's, of course, in the small intestine SIBO, and then in the large intestine, we still use the word dysbiosis as that. And then malnutrition will be another dysregulation of this organ system, poor muscle tone, etc. Prolapse of digestive organs and the uterus, and then bleeding, hemorrhaging, especially more petechial bleeding, that sort of thing. So again, how does this relate, this organ of P, to the biomedical aspects? Let me just quickly review biomedical spleen. What is the spleen in the biomedicine, and what are its functions? Well, the spleen is seen really as a giant lymphatic organ. It's like a giant lymph node for the blood. It's filtering the blood. It's located, of course, in the left upper quadrant under the diaphragm. It's at the tail of the pancreas. And if you look inside, it consists of two different types of tissue. We call the one type of tissue here, you can see in the diagram to the right here, this is the red pulp. And then we have this area that looks like whitish, and we call that the white pulp. And then we see that the splenic artery, which comes in off the aorta, divides into ever more divided blood vessels into arterioles, and they perfuse both the white and the red pulp. And then all the blood drains out of the spleen to the portal vein and goes straight to the liver. The embryology, it's interesting because the spleen doesn't come from the same tissue that most of the epithelium of your GI tract arises from, which is endoderm. It comes from the mesoderm, which is what gives rise to all your connective tissue, your cardiovascular system, and your kidneys. That's all mesoderm. The arterial supply again comes from the splenic artery, which is a branch off the celiac trunk. The venous drainage is via the splenic vein to the portal vein and liver. And then the spleen is innervated by parasympathetics and sympathetics. Now, I'm not going to get into it because it's a little complicated. The parasympathetics actually stimulate the sympathetics in the spleen, which then secrete acetylcholine, kind of weird. But basically, we can think of the vagus nerve having innervation of the spleen, and so do the sympathetics. That's going to be very important because we know that a lot of the spleen functions, especially immunologically now, are very dependent on that autonomic innervation. And depending on the sympathetic versus parasympathetic tone, you're going to get different immune responses to the same antigens via this activity in the spleen. So the red pulp in the spleen, its main function is to filter red blood cells. So red blood cells, again, are anucleated cells. They cannot repair their proteins and whatnot. So after about 120 days, they're aged, their membranes are brittle, and as they squeeze through this fine network of capillaries in the spleen, they rupture and they spill open the red cells spill open, all that hemoglobin comes out, and the hemoglobin is recycled. So the globin, so remember hemoglobin is basically, it's two beta globins with two alpha globins. So that's beta and that's alpha. And then at the center of each globin is a heme molecule. And the heme itself has iron in the middle, and then it's surrounded by a porphyrin ring. And I won't draw that out completely, but it's this big structure that surrounds that. And in hemoglobin, oxygen, molecular oxygen, is going to combine in the lungs with the iron, and then in the tissues it's going to be released. So basically what happens when hemoglobin is recycled, the beta, alpha and beta chain are recycled. They're broken down into peptides, and those are recycled. They go into amino acids. and the liver is going to help with that. The iron is taken out. That's going to be recycled. That's going to be attached to maybe transferrin or ferritin, and transferrin is going to shuttle the iron around, and that's going to go usually to the bone marrow, and we'll reuse that iron to make more red cells. But then the heme, this molecule without the iron, will actually become biliverdin, and that becomes bilirubin, and that's going to be transported to the liver, and in the liver it's going to be conjugated. The bilirubin will have a sugar attached to it, and this is called glucuronic acid. This is a kind of like glucose, similar, and there's an enzyme that attaches it to, and that's going to be excreted in the bile, and that's going to create the pigments, the greenish coloring of the bile, which will become oxidized in the large intestine, and that'll become the dark color of your stool. Some of it will be reabsorbed, and that'll become the dark color of your urine, the yellow color of your urine. So that's the whole fate of heme, the bilirubin. So that's the main job of the spleen here in terms of the red pulp, is to break down the red cells and the breakdown of heme and so forth. So we can say it's sort of a coffin for the red cells. So red cells go to die in the spleen. And it's interesting, in the traditional literature, even in the West, the spleen was seen as a death organ. It was associated with the forces of death, like the death that has to happen to food in the upper digestive tract, the death that happens to the blood, but also even on the soul spiritual life, the death we go through when we go through transformations. And they often connected the spleen with the planet Saturn. You heard of the Saturn return. Every 28 to 30 years, we go through these major upheavals in life, a death process where we have to be sort of reborn after that. So the spleen was the inner image of that activity. But we kind of see that in the red pulp here. In humans, we can actually store platelets. Now, there's some question about, can we store red cells? We know that horses, dogs, other mammals can actually store red cells in the spleen. And so what happens when you need a quick burst of activity, the sympathetics fire, they squeeze smooth muscle around the capsule of the spleen, and that shoots platelets into the blood, and the platelets would be there to actually stop any hemorrhage or bleeding that might occur if you're in an accident. But the red cells would be there to carry more oxygen and to increase metabolism, so you get this burst of energy. And of course, that's why athletes sometimes with doping, they will actually use red cells, inject themselves with extra red cells. So the spleen kind of does that in different animals. It's unclear in humans if that happens. We do have evidence of like divers and things like this that grow up and they've been doing deep diving all their lives and different cultures. They might actually have larger spleens and they might store red cells in the spleen. But for the most part, we think in humans it's only platelets that are stored. But when the platelets are released, they can stop bleeding. So that's an interesting correlation with that Chinese medicine idea that the spleen contains the blood, and that could be partly through platelets. And again, in the fetus, the spleen produces red cells, but not so much in adults. The white pulp in the spleen is involved in immune surveillance. And so basically, as antigens in the blood flow through the spleen, the white pulp is filled with antigen-presenting cells. They're going to take out these antigens, present them to T cells, and then the appropriate responses will be initiated. Now, T cells, it's a complex story, but I'll just say quickly that T cells actually, again, are usually naive T cells, Th0, and they can become, so antigen-presenting cell presents antigen to the T cell, and the T cell then can become either a Th1 activated cell, Th2, Th3, Th9, Th17. I'm not going to go through all of those, but we usually think of Th1. Sometimes we put Th17 here as well, and then Th2. We know that Th1, Th17, that's involved in acute inflammation, in autoimmunity. We get lots of cytokines, fever, inflammation. Th2 is more allergy. And then Th3 is tolerance. Now the question is, what determines, so given an antigen coming in here, being presented, and that's given to the T cell, What tells the T cell to become either Th1, Th2, Th3 in the spleen? Because it's going to make a big difference. If the T cell became Th1, you might have a lot of inflammation from any additional exposure to those antigens. Th2, you're going to have allergic reactions to those antigens. Th3, you'll have tolerance. The body will say, meh, I'm not bothered by that antigen. We now know the signal that determines which way it's going to go is your autonomic system. So it turns out if you have lots of sympathetic tone, lots of norepinephrine, you're stressed out, you're going to switch into either Th1 or Th2. Now, what we know is there's additional hormones that play into that. So high cortisol, that sort of thing, will tend to push you actually into a Th2 response. Low DHEA, high cortisol will push you into a Th2 response. But basically, you're going to create a reaction against that food. If you have adequate vagal tone, interestingly, acetylcholine, it's going to class switch to Th3. You'll get tolerance to that same antigen. So same food exposed, depending on the state of the autonomic nervous system, will create different reactions. And that's very important when we start talking about food sensitivities, which many of them are Th1, or allergies, which are Th2. Basically, to prevent allergy sensitivities, we need tolerance, Th3, and we know we can develop immune tolerance to foods by encouraging the parasympathetic vagal activity into the spleen. Amazing. That is known as the cholinergic anti-inflammatory reflex. Cholinergic after acetylcholine, anti-inflammatory reflex. And you can look that up. There's a lot of interesting work going on there. They're actually now implanting vagal nerve stimulators in people to downregulate inflammation like an autoimmunity. It's pretty amazing stuff going on. In fact, some are saying that in a decade, if this work pans out, we won't need medicines anymore. We'll basically be able to, through the nervous system, downregulate all these inflammatory processes and so forth. I think it's going to be longer than a decade, but I think they're onto something. Again, we have tools like acupuncture, which are already doing that. We just haven't connected it yet to that phenomenon. So that's that immune surveillance and determining tolerance or sensitivity is an important aspect of spleen. Finally, spleen is filtering different bacteria, especially encapsulated bacteria. That would be E. coli, Neisseria meningitidis, which is the bacteria that causes meningitis, Klebsiella pneumonia, which is often involved in respiratory tract infections like pneumonia. Same with H. influenza, Pseudomonas, and Salmonella. These are all encapsulated bacteria. The spleen is a very important organ for filtering those. And so when we actually lose our spleen, if it's been removed, or in conditions like sickle cell anemia, we actually get autosplenectomy where the spleen atrophies and dies. That can lead to lack of immune resistance to those encapsulated bacteria. And that's why people in those situations need to have immunizations for all these that are available. So like the Neisseria meningitidis and so forth. Spleen disorders could involve spleen rupture, like in trauma or so forth. Asplenia, again, this would be a missing spleen or an auto-infarcted spleen. And that would put you more at risk for encapsulated bacteria. So those are the biomedical functions of spleen. So in the next slide here, let's talk about how do we bring all this information together. So going back to our potential spleen-pancreas patterns and biomedical correlates, we can say the Chinese P, again translated as spleen, could correlate with largely the pancreas. In fact, if we think of the spleen yang, that would be more the exocrine pancreas activity. That would be your digestive enzymes and the breakdown of food. So we'd say where there's a spleen yang or Qi deficiency, we would have more undigested food, bloating, gas, that's bloating from the fermentation, the bacteria just ferment that food, and so forth. Spleen yin could be looked at as the endocrine aspect, the insulin aspect, and the anabolic effect. So spleen yin deficiency would really be the same as type 1 diabetes. And that, whereas a yin excess, interestingly, would be more type 2 diabetes, over secretion of that. another aspect of the Chinese spleen would be the actual biomedical spleen, the white pulp, in terms of immune tolerance, the immune surveillance, and the food tolerance that we talked about. And then the red pulp in terms of the platelet activity in the platelet storage. So really the concept of spleen in Chinese medicine should be translated to spleen pancreas. And what's interesting is in the 1940s, there was a French scholar. He actually traveled to China, or what was Indochina at the time, and he started getting interested in classical acupuncture, and he started translating classical acupuncture texts into French. And he translated P as spleen pancreas, and then later translators dropped the pancreas part, and we have spleen. So I just want to make this clear because this is in traditional medicine, is a very important concept. We have in Ayurveda and other traditions the idea of the Agni, the digestive fire, which is really talking about the yang aspect of this, the digestive enzymes and all the breakdown there. So if we look at the correlates, spleen yang in Chinese medicine would relate to the digestive enzyme, the pancreatic enzyme activity, tied in with that arterial blood flow and oxygenation, but this would be the exocrine pancreas. So spleen yang deficiency would be low pancreatic enzymes, low catabolism, low immune activity. And we actually have a name for that in biomedicine, and that is called functional pancreatic exocrine insufficiency. So I'll come back to that in the pancreas pathology section here, but that's important. We often associate this with what's called kidney Qi deficiency. Shu means deficiency. And that actually could be likened to like a low DHEA state. So that's one of your major adrenal kidney hormones. Together with low EPO and vitamin D and things like that. All those are kidney hormones. Excess state, we can look at, this would be more of a stomach fire, but this would be something like acute pancreatitis, that sort of thing. So we see more heat, more metabolism in that area. The Qi of the spleen, or again, when I say spleen here, I'm using the Chinese medicine, the P as the organ. So Qi would be the autonomic nerve activity. So that would be in deficiency, we'd have low vagal tone. In excess, we might think of as high sympathetic tone. And we can actually see those two states, for example, low vagal tone in IBS-C, and then high sympathetic tone in IBS-D. And then we can have maybe a mixed form kind of alternating between there. But that would relate to the autonomic activity. The blood would be, when we say spleen blood, that would be the red blood cell and platelet storage. So spleen blood deficiency would be low platelets like thrombocytopenia, that's the name for that. And then excess blood would be hemorrhaging bleeding. And then yin, again, we can think of that as the endocrine pancreas with insulin and glucagon. So spleen yin deficiency would be type 1 diabetes. And then spleen yin excess would be type 2 diabetes and insulin resistance. So those are important because actually if you access the Chinese medicine literature, there are now specific herbal formulas that address each of these states. And I think this is an aspect that in naturopathy has been underemphasized. We tend to look at one set of herbs for treating the pancreas, like for example, herbs that lower blood sugar. But we actually find that the spleen pancreas can actually be in different states. There are different physiologic patterns. So there could be a deficiency or excess patterns of the yang, the qi, the blood, the yin. And that's not often addressed with the Western herbal therapies, but we could. There are Western herbs that actually do all that. No one's really put all that work together. So that's just something to maybe think about. But in Chinese medicine, we definitely have specific herbal formulas and whatnot that address each of these states. Okay, so that's the completion of the sort of anatomy and physiology of the pancreas. And at the end there, kind of looking at some of the integrative concepts with traditional medicines. In the next videos, we'll look at the actual pancreatic disorders.